Hi, I'm Tatiana Falcone, a child psychiatrist here at Cleveland Clinic Epilepsy Center. Welcome to a series of webinars targeting educational topics for parents of children with epilepsy. We assemble a great team of doctors, psychologists, nurses, social workers, parents, patients with epilepsy, and epilepsy educators to help you navigate all the different challenges that epilepsy may present. Project Care for Epilepsy is designed to improve care coordination, increase social support, provide education, and increase engagement for teens with epilepsy and their families. This project is supported by the Health Resources Services Administration of the U.S. Department of Health and Human Services. The information, content, and conclusions presented here are those of the authors and are not the official position or policy of HRSA, Health and Human Services, or the U.S. government. At the end of each webinar, there will be a link to answer 4 questions about the new topic you just learned about. Please take a moment to answer this quick survey. It will help us understand your needs better. The Cleveland Clinic Epilepsy Center welcomes and thank you for your participation in this educational series. I'm Tatiana Falcone, one of the child and adolescent psychiatrists, and I work directly with the Pediatric Epilepsy Center here at Cleveland Clinic. Today, we're going to be discussing depression and epilepsy, especially in children and adolescents. So my objectives for this presentation today are to help you recognize depression as a frequent comorbidity in patients with epilepsy. One of the complications of depression, and as many other psychiatric illness, is the risk of suicidality. So we're going to be talking about the risk of suicidality in patients with depression and epilepsy. And my last objective is that if your children develop symptoms of depression, you as a parent recognize the importance of the treatment of depression, especially in patients with epilepsy. So if we think about the last 30 years, there's a major progress in the diagnosis and treatment of seizure disorders in children and adolescents. But yet, how frequent the mental health problems are has not changed in the last 30 years. When the depression is not treated, children with epilepsy tend to have poor psychosocial outcomes in adulthood. That's why it's very important to recognize and treat epilepsy in youth and depression. So depression and anxiety are the most common psychiatric comorbidities associated with epilepsy in adults. When someone is depressed, this affects their quality of life, how the patient responds to seizures, and when someone is depressed, they go undiagnosed and untreated, sometimes for up to 3 to 5 years. So it's very important to recognize the symptoms and to look for treatment early. So why do people develop mental illness and depression? So many factors contribute to the development of depression. Life experiences such as history of trauma, history of abuse, biological factors such as problems in the brain, genetic factor, chemical imbalance in your brain, family history of depression or anxiety disorder, and chronic medical illness such as epilepsy. There are also some studies looking at what part of the brain the epilepsy is coming from, and sometimes patients with epilepsy in the temporal lobe might have higher incidence of depression. So when we look at the epidemiological data in general, so if we look at all the population in the United States, the lifetime prevalence of depression is around 3 to 6%. And when we look at the lifetime prevalence of depression in patients with epilepsy, it goes up to 22%. So we know that the depression is definitely higher in younger patients, especially teenagers. So if we look at the lifetime suicidal ideation in the general population, the incidence is around 13%. And when we look about the lifetime, so what is that lifetime? That means like someone in any moment of their life might have these thoughts about suicide. In the general population is 13%, in patients with epilepsy is 25%. So that is why it's very important when someone has symptoms of depression to recognize the symptoms and ask for help, either to your epileptologist, ask for a consult with the pediatric psychologist, or if the depression is moderate to severe, with a psychiatrist. Well, we know that other things that can affect people looking for treatment are the negative perceptions about epilepsy. There was a study by Dr. Austin where they report that in adolescents, 22% in high school didn't know if epilepsy was contagious. We know epilepsy is not contagious, but the perception that other teenagers might think that this might be contagious might impact the social interaction with other kids. 50% of families with epilepsy at some point decided keep the condition secret from others. And that can have a huge impact because it's very important for everybody in their children's life to be on top of the treatment. So parents are not with their kids all the time. So if the child is at school and they have a seizure, but the school doesn't know that seizures are a problem, they are not going to know how to treat it. So it's very important to be open about this illness, and so everybody who's important in the child's life should know that the kid has epilepsy. We also did a study and asked the question, do you tell your school that your child has epilepsy? And 50% of the families, we asked this question to around 350 families, said that they did not disclose the epilepsy to the school. So also, another study, Dr. Bauman reported that 1 out of 4 families that answer a questionnaire believe that having a child with epilepsy in their classroom can change the learning environment. So what all these studies tell us is that we have a long road ahead of us trying to teach everybody who interacts with our kids that epilepsy is not contagious, that it's a chronic illness like any other illness, and that even though children with epilepsy might have problems with learning, that doesn't have to impact any of the other children. So a stigma can make people depressed. So it's very important as a parent to help decrease the stigma about epilepsy. So talking about the diagnosis is important. So what a stigma can do? So when patients don't disclose their illness, then they remain not consulting for the symptoms, so they might not look for help. So also, when we don't talk about our symptoms because we feel that the kids are going to be discriminated, then they avoid going to social activities, they avoid socializing, going to different sports. And you know, there are studies in all different countries around the world where patients have problems sometimes with employment and with renting apartments. So there's a lot of laws currently trying to combat stigma, but anything that we can do to help this is important. When someone feels like they can talk about the epilepsy, we know that the self-esteem is low. We know that they start to develop hopelessness, and they also sometimes avoid getting care because they feel people are going to look at them different. And also, people become embarrassed and ashamed, and they might conceal the symptoms. And at the end, when you start avoiding seeking treatment, the depression can get worse. So it's very important to seek treatment when you need it, get the services that you need, and the support that you need and deserve. So there are some myths about mental health and epilepsy that can perpetuate stigma. So people might say, oh, mental health problems are not common in patients with epilepsy. Well, we know that around 30 to 50% of patients with epilepsy will develop a mental health disorder in their lifetime. The most frequent mental health disorders are depression and anxiety, and also in children, problems with attention and concentration. Another myth is like patients with mental health can hold jobs. We know it's not true. We know that if patients are receiving care, they can be as productive as anyone else, but it's important to get care. In the past, we used to think that there's nothing we can do about mental illness. In reality, we know there are more new treatments. We know the treatments are effective. There are many community support. Treatment works and people recover. There's also many thoughts in the population thinking that sometimes patients with mental health disorders are violent and unpredictable. In reality, we know that patients with mental health disorders are not more violent than anyone else, and it's important to get treatment to decrease the probability of worsening depression. So when we look at specifically in children with epilepsy and we look at the probability of depression, Dr. Davis did a population survey, and he found 16% of the children had some psychiatric diagnosis in patients with epilepsy, 6% in patients with diabetes, and 4% in general population. So even if we see other chronic medical illness like diabetes might have also higher incidence of depression, but in illness that affect the brain, such as epilepsy, the incidence of depression is a little higher. In this study, they use a structured psychiatric interview, so that's our gold standard to diagnose mental health disorders. In this other study, Dr. Kaplan looked at 100 children with complex partial seizures. From those 100 children, 71 had childhood absent epilepsy and 93 were normal controls. 33 of the patients with epilepsy had depression or anxiety. 20% had suicide ideation, none had a suicide attempt. What it was really sad was that 33% of them received mental health treatment. So from those patients who report suicidal ideation, you hope that 100% of them will receive mental health treatment, but only 33% of them receive treatment. So it's our job to make sure that if our child or if our family member is having symptoms of depression, we consult our primary care doctor or our epileptologist and ask them to a referral to a mental health provider. So what are some of the symptoms of depression? So depression is a biological illness, such as any other illness like having hypertension, diabetes. Involves the body, the mood, and the thoughts. It affects many different parts of a person. It affects the way that someone eats and sleeps. So someone who's depressed sometimes can eat a lot of food and gain a lot of weight in a short period of time, or they might feel not hungry and don't eat enough. They might sleep a little less than what they used to sleep before, or they might feel so tired that they want to sleep all day. It also affects the way that one feels about oneself. Like they might feel less than other people, they might look at themselves compared to other children and feel, I'm not as good as them. And they might also feel like things are different for them. It's like they feel that life is different in a way that we can't even perceive it. It's like someone has a pair of dark glasses and it's so hard to see through them that no matter what we're trying to show them, it is always black for them. So, sometimes people think that depression is feeling sad or blue. Yes, that could be one symptom of depression, but for us to be able to make the diagnosis of depression, someone has to have the symptoms for at least 2 weeks. It's not something that it can be wish away. So like saying, oh, don't worry, you're gonna feel better, is gonna do it. Because we know this is a biologic illness, and unless we do a treatment that targets the symptoms are not gonna go away. Some people will say, oh, pull yourself together, you're gonna feel better. Well, we know that it's important to get treatment because even if they try to do their best, they won't be able to pull themselves together. You won't tell someone who just broke their foot, oh, you just put yourself together and go walk like nothing happened. This is a biologic illness and it needs a biologic treatment. Without treatment, symptoms can last for 9 months or even years. So I heard many times from parents of patients with epilepsy, oh, I'm worried if the epilepsy is making the depression worse. Should we wait until the epilepsy is better to then treat the depression? Well, my answer is no. You should not wait because we know that unless you treat the depression is going to get worse, and then it's not also going to help the epilepsy. If the depression gets worse, people become more disengaged and they don't want to take their medicine, and then the epilepsy might get worse too. So it's very important to treat it as soon as it was diagnosed. So just to recap, to be able to make the diagnosis of depression, we have to have these symptoms on the mood, the appetite, the sleep, the daily activities, interests, sadness, crying for at least 2 weeks. So if someone starts having symptoms and they're like 1 or 2 days, that is not depression. For us to be able to make the diagnosis of depression, the symptoms have to be present for at least 2 weeks, and they are impacting the patient in different settings, like at school and at home, at school and in some of the social activities. So if someone who was really engaged and was participating in sports and music, and then suddenly they don't want to do their activities, that's a good sign that things are changing, and we have to pay attention about any of the other symptoms. So they lost interest in their activities, their appetite is decreased, the emotional expression is different. Sometimes you look at them and their face look blank, like there's no emotion. They're feeling sad or empty. Sometimes in adolescence we see more like crankiness, little things will make them mad. Then they start feeling like there's no hope, nothing I can do can help, nothing that anybody can do can help. And then they start feeling like my life is not worth it. No matter what other people do, things are just gonna get worse. And they start withdrawing themselves from their activities, and sometimes they feel like their energy is so low that they don't wanna get out of bed. They feel really tired, and as I'm telling you these symptoms, you might think, well, my child with epilepsy sometimes feel really tired because of their medication. Yeah, that is true. So sometimes when we're looking at chronic illness, we tend to focus a lot in the emotional symptoms. Are they feeling sad or cranky lasting more than 2 weeks? Is the sleep hard for more than 2 weeks? Is the child suddenly getting bad grades at school because they're having trouble concentrating, or they're feeling restless and they can't focus on one activity? Sometimes we can see a lot of physical problems, like new symptoms such as headaches, upset stomach, chronic pain. And we know that sometimes people self-medicate and try to look for other, like drugs or alcohol, to medicate themselves. So if we're seeing that the child is acting different, we normally tend to always order a urine tox just to make sure that alcohol and drugs are not part of what is causing the problems. When the depression starts getting worse, then patients start having thoughts of death or suicide, and that's when the risk of suicide attempts increase. Over 18 million of Americans are depressed, and as many as 2 million of these are adolescents. When we think about depression in children, we know it's not a benign condition. It tends to be recurrent, so people tend to have depression more than one time. The probability that someone has the episode more than once in a year is higher than adults. In children is 40%, in adults is 24%. The risk of the depressions continuing for more than 2 years is higher than 20%. And even after successful treatment, and when I say successful treatment, I mean at least 9 months of treatment with antidepressants, or at least more than 12 weeks of treatment with cognitive behavioral therapy. 40 to 60% of these patients relapse even after successful treatment. 70% of the children who were depressed in their early years tend to have depression when they're adults too. The episodes can last longer, so 7 to 9 months in children with normal cognitive capabilities, and up to 3 years in those children with developmental disabilities. And then we see more problems associated with school, with family, with peers. Sometimes the complaints will be the kid is missing school, the grades are not doing good, then they start suddenly acting different and bullying other people, and this is something totally out of sorts for this kid. We have to think about depression. Suicide risk is also higher in adults who had history of depression when they were adolescents, 5 times higher than in those who didn't have depression when they were adolescents. So what are some of the predictors of depression in children? Gender effects. So we know that by the time the kids hit puberty, depression is certainly more frequent in adolescent girls. We know that after 12 is definitely more frequent. There are many studies trying to look at different seizure variables to see if it's generalized tonic-clonic, if it's complex partial. So far, there are no studies that show us that the seizure variables have an impact on the depression. There's also no studies looking at the suicidal ideation and seizure variables. As I said, there's some studies looking at temporal lobe epilepsy as one of the more frequent comorbidity in patients with depression. And we know that kids with developmental disabilities definitely have more severe mood disorders. And in families who have a lot of family discord, then there's more life events, stressors, and these definitely cause more depression. So if the family is struggling, it's very important to ask for help, like maybe family therapy could help decrease the family discord and then decrease the stress. This is a very important study. They look at 29 cohorts all around the world, and the red line in this slide means the general population, the suicide attempts in general population. The blue line means the suicide attempt in patients with epilepsy. So no matter if the study was done in the United States, in Europe, in Asia, the number of suicide attempts was higher in those populations with epilepsy. So it's very important to recognize and treat depression so patients have lower risk to become suicidal. So how can we prevent suicide? So we have to think about a lot of things. Did the depression appear after a new medication was increased or started? Did the symptoms start after someone was taking a medication for a while and they were doing good and suddenly we're trying to taper the medication off and they start becoming worse? Or are there any other symptoms like anxiety or obsessive compulsive disorder? So it's very important to treat all the different symptoms. So if we notice a rapid deterioration on the symptoms, we have to consult to make sure that the patient is not suicidal. Well, there's a lot of studies asking, are the antidepressants safe in patients with epilepsy? Well, and some doctors might say, well, we don't know if taking an antidepressant will make it worse from patients with epilepsy. Well, now we know. There are studies looking at antidepressants. We call those medications selective serotonin reuptake inhibitors, and we know they're safe in patients with epilepsy. So in Dr. Can look at study looking in different patients with epilepsy taking citalopram, fluoxetine, fluvoxamine, venlafaxine, mirtazapine, and they found that patients with epilepsy who were taking the medications have no difference on their seizures compared with patients with epilepsy that were not taking antidepressants. In another study, they found that if patient had history of depression, that might increase the risk of seizures. But that's why I was telling you before, if you're depressed, you might be disengaged and you might be stopped to take your medications, you might be having trouble sleeping. So if you're not sleeping, your seizure threshold decrease and then your probability to become depressed increase. Dr. Kanner did a study looking at sertraline and he found that it was safe in 100 consecutive epileptic patients. So the conclusion was that if the patient needed medication and the medication was monitored by a responsible provider, and this could be the family doctor, the pediatrician, the psychiatrist, then it's okay and safe to take antidepressant in patients who have epilepsy. How about in children? So the medications that I told you before, selective serotonin reuptake inhibitors are the first line. There are some studies using sertraline and fluoxetine, and they report improvement in 35 out of 37 patients. Sometimes they avoid putting patients with chronic illness in some of the regular trials. So there's no randomized controlled trials in children, but the randomized controlled trials in adults and the studies in open label studies have shown that antidepressants are safe, that they don't increase the number of seizures. So when to refer someone to a psychiatrist? So when you as a parent should ask your doctor to send you to see a psychiatrist. So if you see that your child is depressed and it's getting worse and now they're having suicidal ideation, I think that is a medical emergency. And if this ever happened, I want you to take your children to the emergency room. So if the depression starts getting worse and then suddenly the patient starts hearing voices, seeing things, acting different, like thinking that someone might put something in their food or feeling paranoid about other kids, so that's a severe symptom and it needs to be treated within a week. So please ask for help either from your primary care doctor or your epileptologist to be referred to a psychiatrist. Let's say that you ask your doctor and they put you on antidepressant and the kid's been taking the antidepressant for 4 weeks and the symptoms are not improving. Then we should ask for a referral to a psychiatrist. Or if we're seeing that the children are becoming more hopeless, that they feel like nothing is worth it, they don't want to eat, they don't want to go to school, they feel that no matter what everybody's trying to do to help, things are getting worse, you should consult to a psychiatrist. So when we look about quality of life in children with epilepsy, now we know that having depression affects the quality of life. And we know that the depression can make people feel more withdrawn from their social activities. It might reduce their self-esteem. It might decrease the physical inactivity. So it's very important that we treat some of these symptoms. For years, we have focused mostly on seizure control as our main target for children with epilepsy. Well, that is a very important target, but if the child has any other comorbidities, it's very important to treat them because we want their life to be better. And we know all these other psychosocial factors have a very important impact on the quality of life. So that's why we have to treat them. So we now focus on integrating the care. So we think it's very important to instill hope. When patients feel that there's no hope and things are not going to get better, the depression gets worse. We feel like services and treatment goals should be patient and family driven. When the patient knows that treatment is important, they're more engaged about taking their medication or going to see their therapist. It's very important to have respect and compassion for the patient. And we feel that integrated treatment is very important improving the recovery. So in our service, we have an integrated care clinic where the psychiatrist works closely with the epileptologist, and I see the patients with epilepsy in the same outpatient clinic where they see the epileptologist, so they know that we're always available to treat the symptoms if they need. So it's very important to focus on the patient goals and the functioning. So if you see that your child is having symptoms that are getting worse after a new medication was started, and sometimes the symptoms might be even worse than the seizures, you are the parent. Talk to your epileptologist and ask and discuss what are the new symptoms. They can always help. Patient and family always have a choice. So let's say you don't want to use a medication. Therapy is also a choice, and therapy can be really effective. Sometimes when the symptoms are really severe, we recommend both medication and therapy, but know that the decision is a shared decision and you as a parent have the same power to decide as the doctor. So it's very important to always talk about your fears and your doubts, and I'd rather the patient discuss the concerns with me than say yes, take the medication home, and don't take the medication. So it's very important to discuss your thought process. And this is new, so educating yourself about symptoms of depression is important. So if there are things that you don't know, or if you want more information, there are many resources. You can always ask your doctor for more information. So we know that when patients are receiving treatment integrated with the regular epilepsy treatment, they have less probability to have substance abuse. They have less probability that the symptoms get worse, so they improve their psychiatric symptoms, that decrease the number of hospitalizations, that it might be easier for them to continue doing their regular activities, staying in the house, And of course, we know there, especially in adults, there's fewer arrests, so people are using less drugs, and there's improved quality of life. So treatment works and people recover. So it's very important to know, my main points in this presentation today are that treatment works, treatment is effective, and the recovery process should include the whole family, so patients and family knows what are the important key issues with treatment, and we know that all these treatments are evidence-based to support the patient and the family in the recovery process, that all providers are working together to make your quality of life better and the quality of life of your family. So we feel like providing mental health and neurologic care in a coordinated fashion makes it easier for the patient and the family. And the message that the patient is receiving from the pediatrician, the epileptologist, the neurologist is consistent. So doctors are communicating among themselves about the medication and making sure that each medication that your child is taking works for them and doesn't interfere with their treatment. So how can you make a difference as a parent? Or let's say your child doesn't have any depression, but your child has epilepsy. So I think it's very important to learn and share the facts about mental health issues and comorbidity, especially if you hear or read something that is not true. Educating the public is very important, and I think families are key in this step. Listen to your family member concern. If your child is reporting that they don't want to go to school, if they suddenly start dropping their activities, if they're having some symptoms, share these symptoms with your doctor and talk about them because they can be treated. And as I said before, this is a biologic illness, so we have to treat these patients with respect and dignity. The treatment for depression is as the treatment of any other disorder. So there's nothing wrong about asking for help. We should always support these patients. Don't discriminate against them in any way by house and employment or education. So if you're a parent and you feel like your children are being discriminated because they have epilepsy, there are always resources in all the different support organizations. So always ask for help if you feel that your child or your family member is being treated because they have epilepsy. Well, I hope that I was able to bring some of the important points that patients with epilepsy at some point of their lives can have. And even if this never happened to your child, but this might happen to someone you know, and you feel like that you can share this information about help, I think that would be good. Thank you.